QE1 ProPath, from first glance to final discharge. Don't just pass the exam, transform your clinical thinking. The journey begins. Imagine this: you walk into a Canadian exam room. A patient sits there. Maybe it's chest pain, maybe a rash, maybe nothing specific. What do you do first? Do you freeze? Do you jump to the first disease that pops into your head? Or do you pause, breathe, and follow a path? That path is what I'm giving you today, the QE1 Pro Path. It's not a secret formula, it's how safe, effective Canadian doctors think. From symptoms to SOAP note, from diagnosis to discharge. And if you master it, not only will you pass the QE1, you'll never see patients the same way again. Etiology and risk factors, the why that most candidates miss. Let me ask you something. Have you ever looked at a patient with fever and just said, probably viral, and moved on? That's where many candidates lose ground, not because they don't know enough, but because they skip the thinking. Etiology is not just about naming diseases, it's about understanding the root cause. It's about unlocking the story behind the symptom. Ask yourself, is it acute or chronic? Is it infectious, autoimmune, or malignant? Could it be genetic, medication related, psychiatric, even socioeconomic or environmental? Here's your clinical detective toolkit, VINDICATE. Let me introduce you to your clinical detective toolkit. This is Vindicate, a powerful framework to build and rule out your differential diagnoses like a pro. V stands for vascular. Think blood flow problems like stroke, heart attack, or a clot in the leg. Clues include sudden weakness, slurred speech, chest pain, fainting, or a cold, pulseless limb. I is for infectious. Pathogens are everywhere: bacterial, viral, fungal. Think fever, chills, cough, sore throat, burning with urination, or even a new rash. N is for neoplastic. This means tumors, benign or malignant. Look for red flags like unexplained weight loss, night sweats, persistent cough, fatigue, or a new lump. D is degenerative. Aging changes, chronic wear and tear. Patients often report joint stiffness, back pain, and loss of function over time. Think osteoarthritis or dementia. I again for iatrogenic, caused by our own hands, medications, procedures, or hospital care. Did symptoms start after a new drug or recent surgery? Watch for rashes, bleeding, or drug side effects. C is congenital, present from birth, even if diagnosed later. Consider in children with developmental delays, murmurs, or facial abnormalities. A is for autoimmune. The body attacks itself. Classics include joint pain, fatigue, photosensitive rashes, or dry eyes and mouth. Think lupus or rheumatoid arthritis. T stands for trauma. Recent accidents or injuries, red flags, bruising, fractures, head injuries, or internal bleeding. E is for endocrine and metabolic. Think hormones and chemical imbalances. Polyuria, weight changes, mood shifts, cold intolerance, or muscle weakness. Maybe it's diabetes or thyroid disease. Remember this: Vindicate isn't just a list, it's your clinical compass, especially in MCCQE1. Every time you face a symptom, ask yourself, could it be vascular? Could it be infectious? Could it be something we caused or something congenital? Pathophysiology, the bridge between science and practice. Understanding pathophysiology is what transforms you from a student of medicine into a true clinician. It's the bridge, the vital link between basic science and clinical judgment. In every case you encounter, you must go beyond surface level symptoms. Ask yourself, what is the underlying mechanism? What process is unfolding beneath the skin? Because only when you can articulate the pathogenesis can you truly explain why a patient has fever, fatigue, pain, or pallor. And this isn't just theory. On the MCCQE1, it's your chance to show clinical reasoning in action, to say not just what you see, but why it's happening. Risk factor assessment, the story behind the story. Next comes your risk radar. Every patient brings a unique background of modifiable and non modifiable risk factors, from age, gender, and genetics to lifestyle, occupation, and environment. Your task: identify them, weigh them, link them to your differential, But it doesn't stop there. Safety first. Every encounter is a chance to screen for red flags, suicidal ideation, domestic violence, hemodynamic instability, substance use, abuse, or neglect. These aren't just checkboxes, they're life saving insights. When you demonstrate this approach on the QE1, you prove that you're not only knowledgeable, you're clinically ready. You show that you can take textbook concepts and turn them into real world care. That's the mark of a safe, thoughtful, Canadian trained physician in the making. This mindset transforms your approach from guessing to guided clinical reasoning. Let's play it out. Clinical reasoning in action. Let's walk through some real clinical reasoning. A 25-year-old male presents with fever and cough. What should be your first thought? Maybe it's viral, maybe it's bacterial. But how do you tell the difference? Here's your clue. If the fever is low grade, less than 38.5 degrees, and lasts fewer than 3 days, it's likely viral. But if it's high grade, over 38.5, and lasts more than 3 days, start thinking bacterial infection. An 80-year-old man comes in with weight loss and a persistent cough. This isn't just a cold. You better think lung cancer until proven otherwise. Next case, a 5-year-old child has fever and rash. Sounds viral, right? Sure, but don't forget your differentials. Could it be Kawasaki disease? Could it be leukemia? Could it be a urinary tract infection, which in children can present subtly? Now think of a child with constipation. Maybe it's just low fiber, but maybe it's lead poisoning from living in an old apartment building. This is where etiology meets social determinants of health. And one more, a young woman with fatigue and joint pain. Maybe it's just stress. But maybe it's systemic lupus erythematosus. If you don't stop to consider autoimmune causes, you risk missing a life altering diagnosis. Understanding this process not only strengthens your diagnosis, it gives you the power to justify and defend it. But don't stop there. Think about risk factors. They're more than just background noise. They're the context: smoking, age, family history, trauma, recent travel, socioeconomic status. Every clinical case has a story, and these details guide you toward a working diagnosis. Not necessarily perfect, not final, but clinically sound and flexible enough to adapt. That mindset, that's the line between a memorizer and a clinician. Differential diagnosis, the art of ruling in and ruling out. This is where your inner Sherlock Holmes steps in. Start with one working diagnosis and at least three differential diagnoses. Don't fall into the trap of certainty. Ask yourself what's common, what's dangerous, what's treatable. Only then should you build your management plan, and it begins with intentional investigation. Start with simple, cost effective, least invasive tests. Think urine dipstick, CBC, CRP, chest x ray, then escalate only if indicated. Use your differentials to guide higher level diagnostics: ultrasound, CT, serologies, or even biopsy. And always ask, how will this test change my management? What's my pretest probability? The MCC rewards this kind of judgment. Expect questions like, what is the next best investigation? This isn't just knowledge, it's clinical reasoning in action. Conservative management, also called non pharmacological management, the unsung hero. Here's where many candidates falter. Remember, you don't need a prescription to be a doctor. In many cases, the best care is lifestyle modifications, sleep hygiene, CBT, smoking cessation, alcohol reduction, or simply listening. The MCC honors clinicians who prioritize first line evidence based, patient centered care. You're not just a prescriber, you're a partner in healing. When action is urgent, choose wisely, act safely. There are moments in medicine when hesitation can harm, and action must be taken immediately. But the real question is, what kind of action? Do they need pharmacological treatment like antibiotics, steroids, or bronchodilators? Surgical intervention like an ectopic pregnancy, testicular torsion, or a ruptured appendix? Or is it a matter of safe disposition and knowing where they belong? Before anything else, Assess urgency and stability. Ask yourself, is this patient stable or unstable? Is the condition acute or chronic? Are we offering reassurance or planning resuscitation? Let's break it down. Do they need meds now to reverse a process? Do they need immediate surgery to save a life? Or do they need monitoring in the ward or even the ICU? This critical judgment is called disposition. And here's the danger zone for many candidates: under triaging a serious patient, missing a time sensitive emergency, over triaging a stable one, escalating unnecessarily. Either way, the MCC QE1 will catch it. So here's your golden rule: when urgency strikes, don't panic, don't just react. Pause, think, prioritize, act wisely and safely. That's the hallmark of Canadian medicine. That's the mark of a competent clinician. And if the stakes are high, then your thinking must be higher. Know when to act, know how to escalate, know where to send them, because when lives are on the line, safe practice isn't optional, it's everything. Follow up and psychosocial safety nets. The Canadian Clinical Compass. Imagine you're ready to discharge. The patient smiles, but pause. Ask, are they safe at home? Do they have food, shelter, and support? Is there a risk of intimate partner violence or neglect? Do they need rehabilitation? These aren't extras, they're essentials in Canadian healthcare. Follow up isn't just a calendar note, and it's a lifeline. Always provide safety netting advice, document red flags, refer to community resources. Recommend rehabilitation when appropriate: post stroke, post myocardial infarction, addiction recovery, mental health. This shows the MCC and your future team that you're not just a diagnostician, you're an advocate. SOAP notes, the language of medicine. You can think clearly, treat safely, plan wisely, but if you don't document, it didn't happen. Use the SOAP format. S. Subjective, what the patient says, history of presenting illness, symptoms, risk factors. O. Objective, what you find, vitals, physical exam, labs, imaging. A. Assessment, your working diagnosis plus 2 to 3 differentials. P. Plan, tests, medications, referrals, follow up, rehabilitation, and safety netting. Reorganize your thoughts using SOAP. It's a structure that keeps you clinically sharp and exam ready. Make it a habit. Real time application, the clinical habit. You're in clinic, a patient walks in. First step, are they stable? Second, what's their story? Use the Vindicate approach to think broadly and not miss key pathologies. Then build your differentials. Choose your investigations. Decide conservative, pharmacological, surgical, or psychosocial. Then document with SOAP, plan appropriate follow up, and always flag the red flags. This isn't just a checklist, it's the habit of a Canadian clinician. Closing the loop, why this changes everything. You don't pass the QE1 by cramming PDFs at 2 a.m. You pass by learning to think clearly, reason clinically, pause before acting, adapt wisely. This framework, this ProPath, isn't just for the exam, it's for the clinic, the ER, the ward, and beyond. So here's my challenge to you: apply it in your next practice case. Use it with your next real patient. Build it until it becomes second nature, because once you master this, you're not just exam ready, you're Canada ready.